morning. I am Jennifer Jacoby, the Director for the Institute of Healthy Living and Chronic Disease Prevention. And it's my pleasure to welcome you today to strengthening a palliative approach to care and long-term care in 6 Canadian provinces. This is a situational analysis. Before we begin, I would like to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, unceded territory of the Syilx Okanagan Nation. I would also like to acknowledge that you are joining us today from many places, near and far, and acknowledge the traditional owners and caretakers of those lands. If you are aware of them and would like to acknowledge them publicly, we encourage you to use the chat to do so. I would also like to identify that closed captioning is being used today. If you would prefer, you can click on the closed captioning box and drag it to where you would like, so it is not present in the center of your screen, or you can turn off closed captioning by selecting the hide caption button that's on the menu bar. We'd also encourage guests to place their questions within the chat box, and the questions will be addressed at the end of the presentation. So thank you very much for joining us all today. And I would next like to introduce Lisa Matthews, who is the Executive Director for the North Okanagan Hospice Society. Lisa, over to you.
Good morning, everyone. I am Lisa Matthews. I'm the Executive Director of the North Okanagan Hospice Society, and I am pleased to be able to be here to present this webinar in collaboration with UBCO Institute for Healthy Living. Clara works with me here, and we have been on a fantastic journey of trying to support long-term care facilities in strengthening their palliative approach. So I would like to introduce today's speakers, Dr. Mary Lee Yos, School of Nursing, McMaster University, and Clara Dyck, Education and Resource Leader at the North Okanagan Hospice Society. And they will be presenting Strengthening a Palliative Approach to Care and Long-Term Care in 6 Canadian Provinces, Situation Analysis.
Great. Thank you, Lisa. Thank you, Jen, for that introduction. So we have about 45 minutes with you all, and we're going to get started. We're excited to share our work today. Okay. Oh, navigating technology. Okay, so our time together. We're going to introduce you to the Health Canada study and this strengthening a palliative approach in long-term care. We call it SPA-LTC. So if we say SPA-LTC, it's the program. We're not going to the salon. We're going to be talking about objectives, what our goals were, pardon me, our methods, results, what the results were from the study that we did, recommendations, and then we'll end up with overview of next steps for Health Canada study and questions. Now, if we have some time in there, Mary Lee is going to take us through like the quick version of the SPA long-term care toolkit, where there are all these beautiful tools for strengthening a palliative approach in long-term care. All right, let's get started. So what we found is that there's a huge need to implement a palliative approach in long-term care. So the current average length of stay in long-term care is less than 18 months. And so that when people are admitted to long-term care, they stay for about a year and a half before they die. And that means 1 in 4 residents actually die each year in their long-term care home. Now, this population is often frail and marginalized, and they suffer from multiple chronic conditions, in addition, social isolation. So some of the chronic conditions include dementia and mental illness, which do take unique approaches to a unique palliative approach to care for them. Now, what we found is that when families and patients are in these experiences, decisions often occur late and in a crisis mode. So as a result of these, Sharon and her team at McMaster University developed the SPA long-term care program, and a big part of it was engaging families and residents early on in these decisions. because the idea is we don't want people to feel stressed and in a crisis mode when they're making these difficult decisions at end of life that they're not prepared for. Some of the effects of making decisions in a crisis mode can have lasting effects into bereavement and beyond. And I'm sure you all have either a personal story or a professional story that can attest to this. So Sharon and her team developed this program, and we'll talk a bit about the goals of this program right now. So the goals, there's 3 main goals of the SPA long-term care program, and it really is all about knowledge mobilization and getting the information that we healthcare professionals may know and getting it into hands of other healthcare professionals and the caregivers, families, and clients that are in a long-term care home. So the first goal is to increase uptake of palliative approach in Canadian long-term care homes. So just getting people practicing from a palliative approach. The second goal is to curate, adapt, and disseminate resources for direct care and long-term care, for program development in a long-term care home, and for staff training. And then the third one, which is near and dear to my heart, is consolidating resources into an accessible national repository. So resources that you don't need a password, you don't need to work for a health authority or the government. Anybody, any Canadian can access these resources as needed. So this program is well funded by Health Canada, so all the way into 2026, and the goal is to roll out a palliative program in long-term care across Canada. Now, there's not just Health Canada, there's a lot of great partnerships. Canadian Hospice Palliative Care Association, which is our National Palliative Care Association voice. Canadian Virtual Hospice, which is a great online hospice support and information and education. Pallium Canada, North Okanagan Hospice Society, and SE Health. So I'm just going to read it. Production of this document has been made possible through a financial contribution from Health Canada. The views expressed herein do not necessarily represent the views of Health Canada. There we go. All right, now I'm going to pass it on to Marie Lee.
Great, thank you, Clara, and thank you for everyone for attending today. So I'm just going to give you a bit of a brief snapshot of what the SPA-LTC program is and how it was created. So this program was created to ensure that people with life-limiting illnesses have access to quality of care from the moment they enter long-term care until their death. It was created based on clinical expertise, especially nurses, social workers, best practices, a review of best practices, and also based on the people with lived experience who are also our research partners as well on this program. So through this program, we're really focusing on a holistic view of health, looking at the psychological, emotional, spiritual needs of residents and families as well. So we're really trying to help people prepare for future changes, getting people talking about these advanced care planning discussions much sooner from admission so that they're, like Clara was mentioning, that we don't wait for a crisis mode to happen. We're also here to support the healthcare workforce so they have the tools and education to be able to support families and residents. And we have also developed illness trajectory pamphlets in English and French so that we can provide these to residents and families. So it's a gentle approach of helping them learn more about common chronic conditions such as dementia or kidney failure, frailty. So that's a gentle way of providing information to families and residents as well. We also offer education modules free of cost for healthcare workers, and we have some tailored for nurses, some for personal support workers or healthcare aides, those who are more in the like housekeepers and whatnot. And we have these available in English and recently translated into French as well. And they can be accessed online. And there's different modules about communication and pain management and collaborating in a team environment. We also provide assessment tools, looking at, supporting workforce and using these tools. We also focus on strengthening relationships. So how can we network with other organizations or local community resources to help with providing palliative approach to care? We also provide resources about what to expect during care conferences for both families and also healthcare providers, and bereavement care resources for residents, family, and staff as well, because we do know that staff also become affected with resident deaths as well. And we're also focusing on building the organizational capacity. So making sure that homes are in the habit of performing self-assessment so that they know where their strengths and their gaps may lie so that we could supplement them and support them in that way. And also tracking information about the homes in terms of diversity and things like that. And we also provide guidelines for champions in the home so that we can have some champions who may be nurses or personal support workers or physicians so that they could support others in a palliative approach to care. So that's a little bit of our program in a nutshell, but the website has a lot more. And we've also written some papers that fully describe the program as well. Great, thank you. So the overarching objective of the situational analysis that's funded by Health Canada is to explore the contextual challenges, the facilitators, and resources that could be used to support long-term care homes to implement this palliative program in long-term care homes in various areas in Canada, and we hope to expand across Canada eventually as well. So we're hitting more of certain provinces, but we hope to expand even further, such as in Alberta, which isn't listed here at this time. So what we've done so far is that we've done a cross-sectional survey. So we've provided surveys to staff across Canada. Family members have also completed this survey as well to share their stories and their experiences of the long-term care homes that their family members are currently residing or have resided in. And we also mix this with a qualitative design. So we've also conducted interviews in certain provinces with healthcare workers, administrators, nurses, personal support workers, social workers, and families as well about their experiences in long-term cares and where the gaps may be and what helps to support a palliative approach to care and what currently exists. The recruitment methods included social media, recruiting through Twitter and all of our LinkedIn and all of our existing pages there. And we also have a collaborative network as well. I don't know if we mentioned, but this program is also, it's led by Dr. Sharon Kasalainen. So she is the one who has spearheaded the SPA-LTC program, and she's part of this whole network of people. So she has lots of networks that she has been able to connect us with. So the sample included family care partners, staff, administrators. The numbers aren't exactly balanced. So sometimes we did notice in certain provinces we would have more administrators than frontline staff. So we really tried to do more of that targeted recruitment to get more of the frontline staff involved in these interviews as much as possible. And the data was collected from October 2022, and we're still collecting data in other provinces as well. So the surveys have been analyzed up to date, and we're using descriptive statistics to really summarize the numbers in that sense. And then the interviews we're also continuing to analyze as we complete these. So early findings of the survey, so far we have analyzed 184 surveys from many of them do come from Ontario, British Columbia, and we do have a few in Quebec. You might notice in Quebec we do have a lower number there, and that might be because we've only conducted these surveys. They're only available in English at this time, and the interviews were conducted in English. That's something we're hoping to work towards, is creating more accessibility and offering this in French. So far, some of the key findings that we found is that unfortunately, residents and families are not often actively contributing and participating in palliative program development. So they're not often being asked to join committees to provide their insights or actually help design and make decisions about what these programs should look like in long-term care homes. So we are missing that important piece of information. Diversity data were also not consistently collected in terms of Indigenous status of residents or sex and gender, things in race and ethnicity. So that wasn't always collected across the board. There's also a lack of grief and bereavement support for staff and family and residents. So when a resident did pass away, there wasn't always something in place, or at least something formal in place to support staff and family, and also the other co-residents who may also be grieving that loss. We also found that there was a lack of process for evaluating family and staff satisfaction across the homes. So that's something we can definitely build towards, is just making sure that we are checking in with families to make sure that they are satisfied with the level of care and what could we do differently to support them. And the same thing with staff. How could we support them in the work that they do with residents and family members? So some of the recommendations we've come up with so far is embedding local palliative champion teams to initiate organizational change. So we really need to find these palliative champions, and it doesn't have to be someone formal, but someone who really is passionate in this area, and formally call them a champion so that they could support different disciplines in the home. I've also referenced some SPA-LTC examples in terms of how do we go about choosing some of the champions there as well. So we can do some of that. And there really was a need to have more of that support for champions. So having regional quarter check-ins is something that people recommended, so that champions from different homes can come together and meet and discuss what could be used, or what kind of resources can be shared across, so that everyone can learn from each other and create that sort of momentum and share those best practices. There was also a need to integrate these discussions with palliative champions and also the whole healthcare team in general, so that we can have formal committees where families and residents are involved. So oftentimes we'll have committees about ethics, or wound care and things like that. So there was a need to actually have one dedicated to palliative approaches to care. And the second recommendation was conducting that self-assessment of a palliative approach in current care delivery. So and these came from the interviews that we've conducted in a few provinces across Canada. So people recommended that there really was a need to assess how resident and family-centered care is currently being used from admission. And if there is something lacking, to try to offer that support and kind of supplement that based on existing resources or other homes that are doing something well. There's also a need to embed a formal structure or script for long-term care staff when they are discussing values and wishes with residents. And this could easily be incorporated during the admission conferences, where we really get the opportunity to know the interests and the stories of residents and families, and how we could best support their life stories throughout their journey in the long-term care home. And with this third recommendation, it was to build on the resident and family-centered care approach in long-term care. So we did notice that a lot of homes they're already very focused on the residents and families. So it's really enhancing that, what they're already doing well, incorporating additional practice supports for integrating palliative approach. And some of the recommendations that came up from the interviews was offering more formal education for staff, making sure that they do have paid time to actually do that outside of work. And the ones that were often mentioned was the LEAP programs, and also free programs such as SPA-LTC modules were also things that were recommended, so that they can continue to build their capacity and be updated on palliative approaches to care and the latest progress. There's also a need to provide residents and families with questionnaires to help them prepare for conferences, because oftentimes they weren't sure what to expect, or they weren't sure how palliative care conferences may look different than the regular admission conferences. So providing pamphlets and things like that, questions that they should be asking, or questions they should be aware of during these conferences, was also something that was recommended. In terms of recommendation 4, there was a need to optimize internal and external resources and services to support staff, especially when they're dealing with complex care situations. So there was a need to identify existing physician leaders in long-term care, or nurse practitioners, or advanced practice nurses who can really support the team and be leaders in that sense. There was a need to maximize existing partnerships between long-term care and external organizations such as hospices, hospitals, local universities, so that we could meet mutual priorities. And in the end goal really is to support a palliative approach to care, and making sure that every resident and family have access to these, as when throughout the whole journey. There was also a need to utilize specialized external resources such as palliative specialty teams, hospice nurses, and palliative nursing services. And some of them even had offers that after-hour services where you could call into if you do need that additional support. So making staff aware of these supports was really important. We also found that a lot of the interviewees mentioned that there was a need to empower healthcare aides to collaborate in resident assessments and also share their reports because they do spend a lot of time with residents and families. So it really was important to ensure that they have the opportunities to voice their concerns and also be able to formulate their concerns in a way that can lead to further actions from the part of nurses and physicians and whatnot. So this is where our SPA-LTC program also can offer PSWs or healthcare support workers with some more assistance and education and how to be more how to be advocates among the healthcare team. And then our fifth and last recommendation was to put in place strategies for continuously strengthening, it's a mouthful, a palliative approach as part of a culture of care in the facility. So it's not just offering, one-time education and then we're done, or offering, certain initiatives and then putting that aside. It was trying to continually update and put in place existing processes so that we can continue to ensure that palliative approaches are something that is part of the norm. So the interviewees recommended on expanding on existing assessments. So the intro was something that was mentioned to reflect a palliative approach to care, to make sure that there is some sort of database and that we are being consistent across residents in terms of tracking or recording pain, values and wishes, psychosocial needs, spiritual needs, and making sure that everyone on the team has access to these when needed. There was also a need to create these little shifts in palliative care language through conversation as written information. And examples of these of how we've done that is through the illness trajectory pamphlets, where that can be easily placed in the resident's room or given to families, on admission, so that they could start thinking about this, so that when they do get invited to palliative care conferences, things are less of a shock and they're a little bit more sensitized to the ideas of palliative care. Interviewees also recommended having opportunities for long-term care staff to debrief following traumatic or critical events, such as the sudden death of a resident, which could oftentimes impact the staff and also residents, co-residents and families as well. But not only when there are critical events, they also mentioned when there are good deaths that do happen. There is a need to highlight these as well so that we could learn as a team about how to continue to support these kinds of death in the future. There's also a need to embed indicators into existing processes. So not only specific to hospital transfer admission, but also advanced care planning goals and goals of care discussion. So we really need to put in place some standards in terms of how soon after admission these discussions should take place, how frequently should this be followed up, and also monitoring capacity building activities, how often are these being put in place, and the number of staff who are trained in palliative approaches to care, and ensuring that new staff or orientees or even students coming into long-term care also have access to these educations. So these are some of our recommendations, and we'll go through the overview of the next steps on the next slide afterwards. So what are our next steps for the Health Canada study? We're hoping to collect more survey responses, conduct interviews in other provinces, partner with existing organizations, and work with homes across Canada to address these gaps. I know that Clara is quite involved, and I think I just took over your slide, Clara, so I'm going to pass this back to you, but maybe you want to talk about some of the things that you've been doing in BC as part of the Health Canada study.
Absolutely. Thank you, Marie-Lee. And that's fine. You go ahead and take over. So in terms of next steps here in British Columbia, we've been working with individual long-term care homes. And so whether they're run by the health authority or whether they're a public-private partnership, long-term care home. So really, we're just walking through the process together, doing that self-assessment right off the bat that Marie-Lee mentioned. And there what we're looking for are the gold stars, and then we're also looking for gaps. So I do have to say that so many of the long-term care homes I've been working with have been doing some great work and have a lot of things in place. And what we're doing is we're just coming alongside, and we've got some great tools through SPA long-term care. Those brochures that Marie-Lee mentioned are fabulous. I've used them in my personal life, and they're really helpful to give language to caregivers in terms of the palliative approach and what's the expected trajectory of their loved one with their specific chronic illnesses. We've also been looking at there's some e-learning modules that are very interactive that the long-term care homes have uploaded onto their learning management system and have become part of their orientation and part of their ongoing education. Marie-Lee, while I'm talking, do you want to pull up the SPA long-term care toolkit website? And then I'm going to just share a little bit about situational analysis, kind of what we did in BC to get this fabulous data. And then I'm going to have you cruise through the toolkit and see some of these wonderful tools that are in the hands in our long-term care homes currently in BC. So I'm going to pause this share, or I'm going to just change what we're looking at right here. Okay. Are you all seeing the situational analysis experience now? Are you seeing that, Marie-Lee?
No, it's still the slide, actually, Claire.
Oh, okay. Okay. There we go.
Yep, perfect.
Okay, awesome. So how did we go about getting these 5 fabulous recommendations from our long-term care homes, from the administrators, the family caregivers, allied health, and nursing? So what we did is we spread a wide net. You can see there we sent out 416 individual emails to various stakeholders in BC, with consultants, allied health, and 34 of these were actually personalized key contacts known within the long-term care home. We also sent out stakeholder invites via newsletters, membership lists, and professional development networks that were already in place. And of course, social media. It's part of everything now. From that wide net, there was 13, pardon me. Right, so 13 participants responded by providing key connections to other membership lists. So it's kind of you building on that, and links to local champions. And we sent the first initial shout out, and then we just sent one reminder email after that. Additionally, we specifically recruited from underrepresented areas. We actually got feedback from all 5 health authorities in British Columbia. So we're so pleased that these results come from all of BC, and hopefully they'll be applicable in all areas of BC. So in total, you'll see 84 surveys were collected. Okay, so here's another visual representation. So we sent out those initial emails to some key contacts. We had 13 responses, all followed up individually. And from that, we built onto additional newsletters and email groups, accessing their social media. So there was a real coming together in terms of support from this program from across BC. And there was all the different silos worked together. So I was so pleased to see that. And then we sent one second round email and to get all those surveys. So what I would say is when people are trying to engage networking with long-term care homes, approach province-wide leaders. So reaching out to leaders outside health authorities who have influence, positions of influence in long-term care, such as BC Centre for Palliative Care, the BC Care Providers Association, also the BC Hospice Palliative Care BC Hospice Palliative Care Association. Yes, that one. So not just health authority leaders, we need to be looking at everybody there. We also engaged health authority staff, specifically clinical nurse specialists and educators, and that's really to achieve buy-in and support for the project. And they actually disseminated the survey for us as well. And part of this was sharing information on what's in it for them. So I'm happy to say that since this initial situational analysis, we're actually working with another health authority at the educator level and looking at sharing these resources across the whole health authority at the educator level. So that means them sharing specific tools with their long-term care homes that they oversee and support. The third idea and the approach for engaging and networking with long-term care homes is really fostering relationship. So ensuring that a positive working relationship is built over time. So it's all the things we know: consistent communication, following up as promptly as you can with each private long-term care home that express interest for project participation. So it's really all those things that when you think about who do I like to work with, it's like, well, people that are have a positive working relationship, that answer your emails in the most timely manner, they're pleasant to work with. Those all make a difference in terms of rolling out a new program and connecting with your province as a whole. Okay, so key lessons learned for me and for the SPA long-term care team at McMaster University was leverage your current professional networks. Don't reinvent the wheel. And who can they introduce you to? Also, accessing established email lists. You don't reinvent the wheel. If there's an established email list and you have access to it, by all means, use that. So there's what's established, but also doing some research on new networks and key stakeholders. So it means chatting with your people. Do you know anybody here? And then building up, kind of really building the momentum. I know we've had some cold weather here, so it's like building a snowman. You start small and you just roll that snow and it comes out big. And then actually just calling key stakeholders for buy-in. Like, I'm not saying do cold calls, but yes, introduce yourself, share your vision, share what you're working for, and then you can really achieve buy-in and getting additional access to membership and email lists. Okay, I'll stop sharing that. Are you up and running there?
For the website, Clara, I can start sharing. Yeah.
Awesome.
Okay, I just put the link as well to the SPA-LTC website, so you have access to our website here. That this is what we've created. It has changed quite a bit, so we did revamp it recently. So if you were used to the old website, things might have moved around a bit. So we just have our general description, but what I wanted to pull to your attention is we have our e-learning modules here, which we have some specific for healthcare workers, for the palliative education program, and they're offered in English and French. We also have communication. We also have polishing your PSW or health support worker practice. So those are some of our e-learning modules. We also have podcasts as well that we I think we've recently had a few done there. So we also have some interesting topics for people to listen to, and it's co-hosted by Katie and Sibtane here. So if anyone's interested in those kinds of resources, we have that. Our SPA-LTC toolkit is what Clara had mentioned earlier. So I'm just going to access that. So if you were to choose the language, you're welcome to choose either English or French, your province of residency. So if we were, let's go with BC. And some of our information is tailored, but if it's not tailored to specific provinces, it might just be the same across. So there, if we were to click on introducing a palliative approach to care, there are some resources here and videos, and also these are illness trajectory pamphlets, which are very very hot, and we often bring them with us to conferences. People like the paper format, but these ones you can also just easily print off, or you can send the virtual links. So we have some on different illnesses, frailty, heart failure, dementia. So those are some of that kind of information we have. And so each of these tabs will bring you to different resources. This one's a supporting bereaved family members, and I'm hoping, yes, so we do have some resources. If we were to click on that, that brings us to our bereavement booklet that you can also download and also use. So it's actually it's very nice, and it's easy to share, and it's quite visually appealing and a very short read as well. So it just talks about what bereavement might look like, memory trees, and some strategies to kind of support bereavement and long-term care. And very nice graphics too. I think we might have had someone do those visuals for us. So those are all of our resources that are available, free to use, free to share. Please share them with whoever you might think might benefit from them. And we're always looking at refining these resources as well. So we're always tweaking things, or someone might give us recommendations for, maybe just changing the language here, or making it more, including more information about nutrition or whatnot. So we can also tweak that there based on the information given. So I'm just gonna stop the share here.
Sure. What I'd like to do now, Marie-Lee, we have a few minutes, is I'd like to share kind of our objectives, and I'd like to add some context to the tools that you were sharing with us. I'm just going to share my screen here. Okay, there we go. So you saw some of the tools, the bereavement booklet, which was amazing. And so what I've had in terms of working with long-term care homes is what they do is they tell me stories. They'll say, we had Mr. Smith, he's there one day, then he's palliative, he's in his room for 3 days, he dies. And we have to go in. We've known Mr. Smith for 1.5 years. We have to go in, clean his room out, get it ready. And we've got a new person in the bed the next day. So where does that leave the other table mates? Where does that leave the staff? So that last beautiful bereavement book that Marie-Lee showed, it just talked about some rituals that long-term care homes can put in place. It's just suggestions. So that they can, they can do a room blessing. Some long-term care homes actually have a handmade quilt that's kind of, they cover the person who has died as a sign of respect. And so it's just different ideas in terms of rituals that come out of that. So the other thing about long-term care that many of you know is that they're very busy homes. People have a lot of work. So when they hear SPA long-term care, they don't want another program. They don't want more pieces of paper to add, more work. So what we've done is we've really focused on this shifts in practice. So that's embedding a strengths-based approach. So what are homes already doing? I'll go in and they'll say, yes, we use the palliative performance scale. Perfect. Let's build on that in terms of assessment tools. What assessments tools do we have in the SPA toolkit? Or they have, here we'll do adopting tools and approaches to meet resident and family needs. So they may not have time to do palliative comfort rounds, but what they do is they have their initial intake assessment and meeting with the family, and then they have a yearly assessment and case update. And what we've said is, oh, that's fabulous. Okay, are there a few questions, or can you carve out 5 minutes that we can talk about a palliative approach for this person? So it's really not about adding something more or adding layers. It's about adopting approaches and shifting practice. The other thing that we've heard, like that little story I shared earlier, was supporting staff. So staff really want to do a good job. They genuinely care about the people in the home. And so what are the gaps in staff knowledge, and how can we support those? So as Mary Lee showed you, we've got podcasts. Some people love podcasts on their morning walk. And then there's the e-learning modules that are accessible for everybody, actually. And how can those be integrated into the long-term care home in a way that is accessible for the staff and fits in with their current education practices? So we talk a lot about learning management systems and uploading those e-learning modules there as well. And what these do is they help build confidence and competence organizationally, as a team, and on an individual level. So we've really worked hard at not adding, not making life more difficult, but making life better, and really shifting. It's those little micro shifts that actually, when you add them up, they make a huge difference. And so I'm going to stop sharing this, and I'm going to share my other screen here. And I think we're just about out of time. So you could see SPA long-term care has lots and lots of ways to access them, but Mary Lee put that link in the chat, which was awesome. And oh, look, we've got a YouTube channel. So there's something for everybody here. And then if you'd like, I did share the first 3-page I shared about our process here in BC. You can get your handy phone out, and you can QR code that and get access yourself. That's also on the SPA long-term care website. So that's us for now. I'm going to send it back to Jennifer and Lisa in terms of questions. I'm so curious because this is shared across Canada, kind of if there's any questions across the board for Mary Lee and I.
Brilliant. Thank you for sharing. I guess I will start it off potentially, and then toss it over to Lisa, and potentially then see where this goes as far as the conversation. I'm going to encourage our participants to continue populating the chat. There's some beautiful questions in there. So I'm going to start it off with one that indicates, hello. In BC, the health authority states palliative care can be provided in long-term care, LTC. I was my wife's essential giver for over 5,000 hours during the pandemic. She died recently of FTD. I'm sorry to hear that. My sincerest condolences. With the individual goes on to read, with an advanced care directive, section 7 and 9, I politely advocated for palliative diet at 2 months before she expired and comfort care at the time of death, both denied or subverted. At her death, I was provided with cookies and Kleenex. Why do they discount or ignore advanced care directives? I believe this is a charter of rights issue under section 7, security of the person, autonomy. What other remedies might we see? Thank you for that question. I'll hand it over to Clara and me.
Yeah, I'm just sometimes I hear it and I read it as well. I see. Yeah, and I do want to echo Jen's condolences. And I do have to say, our family caregivers are our unsung heroes of our society. So we have a hero in our midst here. Why do they discount or ignore advanced care directives? So what other remedies where we'll seek? I'm an educator. I will go to education in terms of educating that palliative approach with the people that are caring for loved ones. So the focus of this program is really to help staff understand that what is the most compassionate thing to do in this moment in terms of end of life care. What does this person actually want or need? What does their body need? So when people are actively dying or their nutrition needs are changing at the end of their life, we kind of really go with what do they feel like eating? Do they want ice cream and jello and that's all they want to eat? That's fabulous. We go for it. But I'm just wanting to dive into this. Why do they discount or ignore advanced care directives? That's a tough one. We're in a death denying society, and people really, at all costs, try and keep life going. And we also as a society, have this belief that, I don't want to speak for everybody, but food is love. So feeding people is so intrinsic to showing care and care across ages. So that's a big part of that as well. Did you want to jump in on that, Marie Lee?
Yeah, I also wanted to share my condolences as well. And it's something that, we do hear from time to time that even though we're advocating for earlier palliative approaches to care, it's not always happening in the home. And there's often, not often, but sometimes there's a mismatch of values between our understanding of palliative care and the home's understanding of palliative care, and whether or not we're actually seeing things. And it seems like to me that this individual was definitely understanding, the need for advanced care directives, trying to advocate for that as much as possible and early on as possible. But the homes, sometimes I find that maybe the homes think that if you start asking for palliative care, that it means like they're going to have to provide extra resources for this person. And it doesn't necessarily mean that they're going to need, for example, a one-on-one care provider, like a nurse or personal support worker. It just means that we need to start thinking about things sooner, having more discussions with family members about what we would like a good death to look like, since we know that this is imminent. And this is where it doesn't necessarily need to be about, medications. It's really about what Clara had just mentioned, people values and wishes. How can we make sure that we ensure that their quality of life and their story are upheld up until the very end of life? Making sure that all of the staff are aware of this person as an individual shouldn't have to wait until the end of life or near palliative circumstances. It really should happen on admission. um, and just checking in with families. I think oftentimes staff are very focused on making sure that the resident they're not in pain, they're provided with pain medication, they're comfortably placed, they're repositioned, they have pillows elevating. But the families are the ones that are there witnessing everything and probably seeing more than the resident themselves when they are more in like a sleep state, for example. So we really can't forget what the families are going through. Remedies for this situation, I think it really comes down to that home needing to reevaluate what could they have done differently so that this does not happen again to the next family, to the next resident when death does occur. Really, they might actually need to, and I'm just, just hypothesizing, they probably need to have a better look at what kind of resources they have available and what they should be seeking, and connecting with homes that do palliative care differently or well, or actually and that's where it comes down to where interviewees recommended we really need to measure that family satisfaction. If I was to provide this individual with a satisfaction questionnaire, I think this home would, in this circumstance, probably wouldn't have done very well. And we need to listen to what is needed and what we could do differently and better. And that's why we really need these committees, opportunities for open dialogue, so we could talk about palliative care sooner than later, so that these kinds of events can be avoided. I don't think it's a very simple situation. We can't go back in time, unfortunately, and try to fix things, but we can try to move things forward and do things differently for the next person so that this doesn't happen or happens less. And if it does happen, we have some things in place to kind of ensure that strategies are in place to address this and that we are being accountable for the care that's being provided.
I think you truly identified it. it's the element of understanding and education. And I think that's in part what we're here today to share, is different ways to learn from each other and communicate with each other through education and through different formats. A participant indicated in the chat that potentially writing a letter, whether it be to the board chair of the health authority or potentially to a different organization, that would be my thought as well. Just to share your experiences in a manner that things can move forward through education and through sharing experiences. And I think that's where we can start to really advance care for individuals. Thoughts on the approaches to share information and share knowledge? You've shared it here through many different resources, inclusive of the YouTube, which was really, I wasn't aware of that, so that's phenomenal. So there's different ways and means that individuals can access information. Potentially, could you talk about how they could share information? Is there a means that they can do that across caregivers or within the care community?
Do you want to take that one, Marie-Lee?
Yeah, that's a great question, Jen. And I think one thing that we've done with our SPA-LTC program and our projects is that we often have people with lived experience join us as research partners. So that's one way that, and we've heard lots of positive feedback from our research partners. We are currently seeking some as well. We're having our call, but they really take part. They share their experiences. It's mutually beneficial. We get to learn from them. They're providing input on our research materials, making sure that our priority is aligned with what they need and what they're seeing. But they also have opportunities to learn from other research partners who are going through the same thing, or sometimes they're at more advanced stages, or their family members had passed away. So they have lots of pearls of wisdom to share with the next person. So that's one way we can do the caregiver resource sharing among, and it's kind of, it's a nice way to be recognized. We also have our research partners tender conferences. So they were with us at the last two Canadian Association on Gerontology conferences, and they actually presented with me and they shared their experiences with a larger audience. So that was a really nice way to recognize their experience as being valuable and important part to really showcase to a broader audience as well.
Great, thank you.
Yeah.
Lisa, I'm uncertain if you can see the chat, but if you can see the chat, did you want to go ahead and ask our panelists the next question, or?
Sure.
Thank
The
you.
question, I'm just going to pop up there, Jennifer, to a question that was a little bit earlier, wondering how this program incorporates requests for MAID provision. I know that some locations do not honor a patient family's wishes, forcing them into less than humane options. And I was wondering if either Clara or Mary-Lee would like to address that.
I can address that. So this is talking about a palliative approach to care. Medical assistance in dying is what they call a medical procedure. So it's something that a procedure that they would take on with their family physician or nurse practitioner. Now, legally under the law, everybody has access to a medically assisted death. So if the locations are not honoring that person's request for an assessment or a medically assisted death, then that's actually contravening the law. As far as I know, medical assistance in dying is not addressed at this moment with the SPA long-term care tools. Did you want to talk a bit about that, Marie-Lee?
Yeah, absolutely. Yeah, unfortunately, I don't think we go about talking about MAID. I think it would be more in the earlier stages, and that discussion would most likely happen in a primary care practice setting where that person maybe is well enough to make those decisions. Not to say that people in long-term care aren't at that stage and can get into those kinds of decision-making discussions. But one thing I wanted to take note of is the second part of that comment about not honoring patient family wishes, forcing them into less humane options. So what we do advocate through the SPA-LTC program is really listening to the families, looking at the stage and kind of thinking whether or not these interventions or life-sustaining interventions are very beneficial. So what we do through the program is through the advanced care planning discussions with families, it's really important to bring about, if something was to happen, maybe it's not ideal to transfer the person or the resident to a hospital setting where they might, even further decline. It's not their familiar setting. They might have, more high risk for delirium or whatnot, or intervening in that way, or, some of the more basic ones are like CPR, maybe that's something that we really need to look into, and not, for example, if someone seems to be pushing away food, not trying to get that person to eat as much as they used to. So kind of using food for comfort rather than life-sustaining measures or nutrition. I think so that's those kinds of things we really need to listen to families and also residents, and looking at those nonverbal cues about, when treatment it looks like it's no longer necessary or not even beneficial. So we need to reduce medication. So instead of someone taking, like 20 pills a day, can we only take the ones that are essential, remove the supplements or the vitamin Ds, and looking at like intravenous, if someone is no longer able to tolerate, antibiotics and things like that, do they really need that intravenous solution to provide that? Or should we just, look at comfort measures at that point? And how often are we going to treat, urinary tract infections if it doesn't seem like there is a benefit to that at certain points in time? So we really need to look at the whole situation and have that fulsome discussion with families, so that no one's being forced into something that doesn't go along with the wishes of the residents and the families as well.
Thank you for identifying that. The aspect of that.
Do we want to, Jennifer, do we want to ask that last question? Because we have very few minutes left.
Sure, we can try. We'll have to limit the answer very tight across the panelists. So this question reads, I'm a recreation therapist and I'm wondering what area we could assist with palliative care. Always trying to learn about more than just putting on music for the person and finding out if they need a spiritual visit. What other ways could we support them?
All right. Good luck with keeping that short, but we'll keep it short. Palliative care and a palliative approach to care is a team sport. So there's absolutely so much a rec therapist can do in terms of assisting with palliative care. And we talked a bit about a palliative champion team. That palliative champion can be a carried, a rec therapist, a nurse, anybody who has the passion for palliative care. It sounds like this person has a passion for palliative care. And so then the next step is getting information and education to that person to incorporate it into their practice. Do you want to add a sentence, Marie-Lee?
Yeah, I'll be brief too, Clara. This is a very great comment. And I think recreation therapists are, their work is so very valuable, especially in long-term care, to provide that stimulation. I'm just going to pull a little bit of a plug, but my thesis work, my PhD thesis, my postdoc work is all about multisensory interventions for people living with dementia, especially in the advanced stages. So recreation therapists can really do a lot more than just putting on music and finding, I think you really get into the stories of individuals, of residents. You're great at having that discussions with families as well, and finding out what they used to do, what they used to enjoy, what kind of foods they like, what kind of music they like, all kinds of things in that sense. So that's a really valuable aspect. So that all falls into palliative care as well. So those social, psychosocial needs definitely have a place, and recreational therapists definitely have a place in pulling that out and sharing that with the team so that we can all honor the resident's story.
Thank you. Very well put. And thank you for changing the slide so that we can see where the website as well as social media resources and LinkedIn resources and YouTube resources can be found. I wanted to start by thanking our panelists today and Lisa for co-hosting with me. The North Okanagan Hospice Society truly is a valuable resource and community member for us here in the Okanagan, and thank you for your leadership. For our participants, please watch for an evaluation form. There'll be one coming your way through email. And as we close, I'd like to wish everyone a very happy Monday. Thank you for attending. And please watch for our Embrace Aging updates coming close, because March is not far off. So they'll be arriving in your inbox soon. And we look forward to seeing you at the next Institute for Healthy Living and Chronic Disease Prevention event. Thank you very much to everyone for attending today. Have a splendid day.